Hi everyone, it's Vaishali from the Caregena podcast, and here I am today with Prashant Yadav, who is a senior fellow and professor.
Thank you. Glad to be here, Vaishali.
Yeah, thank you for being here. So, my first question for you is could you share a deeply personal or impactful story that inspired your involvement in this work?
Yeah, so what I do now is supply chains for health products around the world, some here in the US, a larger part in countries around the world, including in Africa, Southeast Asia, Central Asia. And when I started my career, I was largely focused. I trained as an engineer. I worked for a couple of companies where I had the luxury of having managers or supervisors who were great mentors to me. They taught me that analyzing things rigorously, using good methods, good sort of systematic tools has good long-term outcomes. So I was never trained to be somebody who would just use ad hoc methods and techniques, but rather keep focus, keep stringency, keep rigor. So the two jobs that I had before I embarked on this journey in global health and supply chains for health products were in some ways instrumental in shaping how I think and view the world, what my perspectives are. But I started largely in the area of using my training in optimization, applied mathematics, supply chain management to help get products on the shelves of retail stores. Right, my very first projects were focused on looking at things such as wedding bands. How do we make sure that somebody who walks in a surprising visit to buy a wedding band at a store in anywhere in the 50 states or in Las Vegas can find the size, the color, the style they're looking for, and how can retailers and the manufacturer collaborate better in making this availability higher. I also worked in some projects which were related to the Department of Defense. How do we make sure that equipment that is needed in field operations is serviced better? But most of these projects were focused on getting products that people need for individual benefit, right? So if I want to get a consumer product in the shelves of a retail store, it makes my own life better. I get derive some individual benefit from it. And at some point in my life, I started asking the question, all the tools and techniques that I've learned in my training, why can't they be used for things that society cares more about? And as I started embarking on what this means, my own realization was that much of what we've developed as tools and techniques for supply chain management work exceptionally well to get something that I want at my doorstep the next morning, in some cases in the next 6 hours, in some cases in the next 30 minutes. There we have put enormous amounts of science, technology, creativity, and entrepreneurship. But then when you ask the question, can I get medicines, or can someone who lives in a low-income country, someone in a rural area, get the health products that they need with the same expediency, with the same service component that, yes, if I order now from the prominent e-commerce platform, I am 100% sure, almost 100% sure, that I will get that product in the next 6 hours if that's the kind of delivery option I choose. Why can't we get the same for things that society benefits from when an individual consumes them, such as medicines, vaccines, preventive health technologies? And then I realized that we haven't put as much thought, as much research, and as much entrepreneurial energy into this field of applying the techniques of optimization, supply chain management to the area of products with social benefits. So over time, that has become what I do for a living. It has been shaped by my growing up I grew up in India, I grew up in multiple cities, but all around me, I saw people who were underserved by the more mainstream channels. India before the 90s had product availability in whatever were called as retail stores or kirana stores, as we would call them, was very limited. The assortment was very limited. There were only a few items that you could get, if you could. In some cases, they were stocked out. What we now call as supply chain systems were almost non-existent. And then it was abundantly clear that even if those systems were progressing somewhat in the 90s or the late 80s. They were progressing mostly for consumer products, and the equivalent for socially beneficial products were almost non-existent. So I saw this all around me, and then when I got an opportunity and a chance to apply my training to such products, I said that's what my focus should become. And in doing so, I mean, through meeting good people, mentors, people who connected me to the right kinds of research questions, to the right kinds of applied problems, I made for myself a career in what we call as healthcare supply chains, or oftentimes in a specific setting, global healthcare supply chains. So that's my own journey and how I landed onto what I do now.
Amazing. Yeah, that's wonderful. And yeah, I guess when reflecting on your work, what are some of the most formidable challenges you've encountered, and have you navigated through them?
So the challenges, Vaishali, are we like to think of systems, and if you train in applied optimization, mathematics, operations research, you like to think of problems as a well-defined goal and objective and a set of constraints. And you say, how can I solve this problem to achieve my objective, whether it is to maximize something or minimize something, subject to the constraints I'm given. Right? So that's the mindset with which people oftentimes address these problems. The biggest challenge I have encountered in the last 2 decades of working in this particular sector of healthcare supply chains in emerging markets and frontier markets is that defining what is the objective, what is the goal, is not always straightforward. It's a social process that requires you to ask questions to a very diverse set of stakeholders, right? If you ask the question to a patient, what is their objective? If you ask the question to a provider, and when I say provider, I'm talking about a nurse, a medical officer, a doctor, someone in the administrative structures of the healthcare system, what is their goal? And then you go to the Minister of Health or those who allocate large amounts of funding for the healthcare system, those who control the purse strings essentially, and then you ask, what is your goal? Right? So the goals are never a single goal, right? They are very varied goals. And then you've got to figure out what is the hierarchy amongst these goals? What is it that you want to solve for first and for whom? And then the same thing applies to the constraint side of this work, which is you like to think of something as, well, this is a given constraint, I cannot change this. But constraints are also deeply political. They are not just technical. You may say the country doesn't have budget to allocate more money to buying more medicines. But that budget constraint is not a hard constraint. A head of state, a minister of health, a leader in the healthcare sector have the ability to essentially alleviate that constraint by allocating more money. So figuring out what is truly a hard constraint and what is a constraint that is changeable has been a challenge in my work. And I say this as a challenge because cognitively, you struggle to figure out which one do you call as hard constraint, which one do you call as a soft constraint, which one do you fight for and say, changing this a little bit will get me a lot more in terms of outputs and outcomes that I'm seeking in my work, and which are the ones that are not worth fighting for because they are either so hard or their political economy is so complex that you will never be able to navigate them. Understanding this sometimes takes much, much longer than what it takes to solve the problem, to apply the techniques that we've learned to solve the problems, etc. So my challenge has been, I started my career in addressing these problems with a strictly technical lens. And then I realized I wasn't delivering as much, right? I may be getting excited about writing a few research papers on them, some of which will go win awards from professional societies, but things were not changing on the ground, right? And the only way things started changing on the ground was when I started paying a lot more time, energy, effort, and attention to understanding the political economy of what is the hierarchy amongst the objectives to different stakeholders, what is the distribution of power and influence amongst different stakeholders, and what constraints can we overcome and what constraints we cannot overcome. So that's a challenge that I've encountered. And I'm happy that over the last decade or so, I have at least gotten a little bit better in how to navigate this than I used to be 20 years ago.
Yeah, I guess following up, I'm also really passionate about global public health. So, yeah, like as you mentioned, knowing the political economy. So, my question is for sustainable practices for like technological advancements, for anyone who is like, maybe like aspiring to make products that are focused on underserved populations, whether it be through, like having like making resources available to them or just like online education practices, what would you suggest to them, especially for areas, where it's surrounded by political environments?
Yeah, so I think we like to, so firstly, I think what we call as global public health, we've got to ask the question somewhat more thoughtfully, meaningfully, and rigorously. What does it mean, right? Does it mean that people in high income countries trying to contribute to the health of people in low income countries, which is oftentimes what people imply when they talk about global public health, right? If
Yeah.
that's the starting definition, we've got a structural problem. And your question about do we design the products right, whether it's an online educational material or actual health technology, how should we design it? Those I can attempt to answer them, but I think if the construct is that high income country technical experts and resource and purse string holders deciding how to manage, design, and run health systems, how to provide new health technologies for people living in low income countries, that's a flawed structure. That's a flawed starting assumption. So, if the definition is right, which should be where health truly is, I mean, the components of health which create true global public goods, as you would call them, and there it is in our common interest collectively to think about health systems, other problems of health. That's where I think there is more merit and saliency to the question you pose. So, if I'm developing a health technology, let's say a new medicine, a new vaccine, or I'm developing a new knowledge material which will help people provide healthcare better,
Mhm.
I've got to first ask the question, is this a true public good, or is it specifically targeted to some population segments?
Mm.
Oftentimes it's a humanitarian cause, and
Yeah.
I'm not saying that's not worthy, and it's equally important for people to do things for a humanitarian cause, which is I care about people in rural and poor settings who do not otherwise end up being the first, like the forethought of someone who's designing a new medicine, a new vaccine, a new diagnostic, or a new health product, right? So designing for that population segment is a great humanitarian effort. But in doing so, we have to co-create, right? Once again, we can't say that I will be in a very well-resourced institution in a country in the global north, and I will use all of the resources at bay to design something which I believe will be more useful for people who live in low-income country settings. I think it has to be co-creation
Okay.
because there are so many aspects about the use of health technology, and I'm not just talking about anthropological or socio-cultural things, even technical things, where the knowledge is non-codifiable. It's tacit knowledge which sits in the minds of the nurse or the health officer at the clinic. Right? That knowledge of why or why not will it be useful never gets codified in anything which we can bring and start using in our design process. That requires the people at the front lines to very well be co-creators and be a part of the design process, right? So it's bottom-up design.
Mhm.
So if you do bottom-up design, it takes effort, right? It's much easier to work in your lab and build something versus saying, oh, I'm going to do a prototype and then take it for multiple versions of that prototype being beta tested by people who are at the front lines of providing healthcare, whether it is a health technology or it's an online material for educating and so on.
Hmm.
So my response will be co-create, um, involve the people who are going to use it. And then also, I think one common misconception that I see very widely is that we can design things for people who are at the lowest socioeconomic quintiles, or what some would call as at the bottom of the pyramid, right? We can just design for
Hmm.
the poor, and then that will be the best use.
Yeah.
We have to understand and accept that the way technology diffuses, technology of any type, the way technology diffuses is from top to bottom. Top
Hmm.
implying at the higher socioeconomic quintiles to the bottom. So the
Hmm.
poorest of the poor look up to the next socioeconomic quintile above them and ask the question, are they using this kind of a phone? Are they using this kind of a diagnostic device?
Hmm.
And then they say, if they are, then I will use it too. But if you say, no one else, the city dwellers are not going to use it, the affluent are not going to use it, but because you are poor, we're going to design a special health technology for you and for you only. That is where adoption faces significant barriers, right? There are many, many examples. So when the first rapid diagnostic tests for testing whether somebody had malaria, when the first ones came out, they are a little sort of lateral flow, little strip, right, on which we can, now with COVID, we've seen more of them used commonly, but they're little strip
Hmm.
tests. And they were used only at the frontline clinic level. Whereas if somebody went to a district hospital, they would still take a blood specimen, put it on a slide, and look it under a microscope and look for malaria parasites,
Mm.
right? So
Yeah.
if I'm a patient, if I'm the mother or father of a child, I take them to a frontline clinic in a rural area. They just do this rapid test on a strip and then tell me the answer in 5 minutes. If I go to a district hospital, they put it under a microscope on a slide and then decide. I would ask the question, why is it that when I go to a district hospital, it's under a microscope, when I go to a frontline clinic, it's a rapid test, right? Because we targeted to put the rapid test only for the frontline health workers.
Hmm.
Adoption increased over time when the district health officer also started using these rapid tests instead of just using the microscope and the slides. So the purpose of this example is to say we have to understand, internalize, and accept that most health technologies will diffuse from top to bottom.
Hmm.
So we can't just design for the poorest of the poor. We've got to
Yeah.
design for a larger segment of the population. It will achieve diffusion. I commend the efforts to also keep in mind adoption at the lower socioeconomic quintiles, but
Hmm.
not just designing for the lowest socioeconomic quintiles. The second thing I'm going to say about what should people keep in mind around this is people who, whether to use a technology or not, the demand side of the supply chain, as people in my profession would call it, they they aren't just the patient or the mother of the child in healthcare. In consumer products, it's much easier because you can do a focus group interview with those who are likely going to use your product, essentially end customers. But
Hmm.
here, it's a complex interaction that happens between the provider of healthcare and the patient or the patient's caregiver. And that complex interaction has a lot of back and forth. Back and forth, not just in terms of verbal communication, but in terms of various other forms of communication that occur in that patient provider interface. And then on top of that is a regulator who decides whether or not the technology is safe, efficacious for use. And there is a payer, because payment oftentimes is done by a third party, whether it's the Ministry of Health, the government, or some other third party. So all of these parties have to be involved, and designers of technology oftentimes struggle to take all of these viewpoints into account in a meaningful manner. And they think, I've designed something, why wouldn't somebody use it? I've shown it in the lab. This is a great technology. This has the potential to improve people's lives, healthcare. Why aren't they using it? And the predominant reason is we haven't looked at this complex interaction that goes on between the different stakeholders.
That's amazing. Yeah. And I really like the point that you brought up with adoption versus kind of like, as you mentioned, isolation, as certain groups of people could feel isolated. My next question is, what specific goals and aspirations drive the work that you engage in? Specifically for sustainable health practices, what really brings you to achieve everything that you've worked on?
Yeah, so like I said, there is a hierarchy of goals, lots of things that we tend to focus on, but if there is one that I fundamentally believe drives me and many people who work with me is health equity, right? People who are wealthier, more privileged, live in urban affluent areas, the options for receiving high quality healthcare are very many for them, and they can afford them, whether it's through insurance, through government payment, their own out of pocket, etc. Right? Whereas those who do not have the means and resources for achieving such choice in their healthcare, those who can't say, oh, I'll go to this clinic because I think this one is better, for whom choices are very limited, and the places they can go to, the clinic or the pharmacy or the shop where they are trying to access healthcare, that's oftentimes underserved by the mainstream providers of healthcare and healthcare technology. The global pharmaceutical company, that's not the first market segment that comes to mind to a large global company. Some of them do, and they're starting to care more, but that's not the first or the primary driver. So health equity is the top aspirational goal for what I do, and the way it translates into what I do is availability of medicines and health technologies in settings which are either rural or serving the somewhat less affluent in the urban areas. That's what I focus on. How do I make sure that all kinds of health technologies are available in such settings? And that requires then creating a cascade of other goals and metrics. But the first and foremost sort of North Star is ensuring greater health equity in the world.
Yeah, that's wonderful. What novel approaches has your work embraced to confront complex issues or adversities?
Sorry, Vaishali, I didn't hear very well.
What novel approaches has your work embraced to confront complex issues or adversities?
So, technology plays an important part in how supply chains operate for all things. It also plays an important, equally important, if not even more important part in how supply chains operate for health products and medicines and vaccines and diagnostics. So, novel approaches that I've used in my work are two types. First is technology for supply chain optimization. And when I say supply chain optimization, I'm referring to how much product to order, how to forecast, how many levels to have in this system, how much inventory and stock to keep at a clinic versus in a district. Right? Lots of these operational questions. How many times should I send a truck from a warehouse to a clinic? Should I send monthly? Should I send once every 3 months? Should I send weekly? Those sorts of questions have been answered quite well using new technology for the big companies that serve us, right? The big e-commerce companies and so on. And academia has helped develop these tools and techniques, and companies have even refined them, in some cases advanced them even further. So one part of novelty in my work was to borrow as directly as I can from these approaches. So if Amazon Data Science is using a new technique for last mile delivery, why can't we use that to do similar deliveries in healthcare and resource limited settings? Examples would also be new logistics technologies, such as the use of drones for delivering medicines, right? So that's borrowing directly from what's happening in the mainstream world. The second part of novel approaches is when things that work in the mainstream world don't apply to healthcare and resource limited settings. And examples here would be when you've got to design systems that are simpler because you don't have the luxury of computer systems, you don't have the luxury of sophisticated information technology. Can you design systems that are simple, rules, methods, heuristics that are simple enough that someone who is truly at the front line of providing healthcare and is usually very pressed for time, because if you see a clinic in many of the places that I work in, The time the medical officer or the nurse comes to work at 9 o'clock, there is already hundreds of patients who've lined up for treatment, and by the time they close, there's still many left who have to be turned away. So in that environment, expecting someone to spend time with entering information into the kinds of systems that warehouse operators or retail pharmacies or others do, where they have a little bit more luxury of time. So we have to design systems that are simpler, are less taxing on the time of the frontline health worker. We should not tax the time of a frontline health worker anywhere in the world. A pharmacist in a pharmacy should spend the least amount of time. But it becomes even more important in the kinds of settings I'm describing. So the novel approaches are systems that can achieve the same level of sophistication in terms of creating the right demand signal, the right way of figuring out how much is needed without overburdening the frontline health worker. That's where we've applied many novel approaches. Some of them are about how does a healthcare worker communicate what they know about future demand? Do they communicate using voice instead of writing into a data table? Today we have natural language processing techniques which have become much more mainstream, but even 10 years ago we were trying to use them so that a healthcare worker doesn't have to just enter a number of how many units of a medicine or a health product do they need, but they could enter something which is a little bit more descriptive. And then we could translate that descriptive into a meaningful unit of analyses for deciding how much to send and so on. So that's where the second part of the novel comes in.
Yeah, I think it's a great point, like how you mentioned the natural language processing. So, is your opinion on how AI is kind of revolutionizing, like a bunch of industries such as like healthcare and tech? Um, so I guess like, what are your thoughts on how AI could help physicians or pharmacists or, anyone in the health industry and how, either jobs may be impacted or how these sustainable health practices may be affected.
Yeah, so Vaishali, I won't comment on how will AI impact physician practices in medicine more generally. There are people who are far better equipped than me. But
Hmm.
what I want to highlight is that when we think about what are the best use cases for AI in healthcare and where do they reside, one question that is incumbent on all of us to answer is there are some use cases which are replacing a physician, which are replacing a pharmacist, or which are making them more productive. But there is a large part of the world where there are no physicians. There is a large part of the world where there are no pharmacists.
Hmm.
So if we have technology that has advanced to a level that it can determine people's prescribing, what medicine should be prescribed, or it can determine how much should be ordered by a pharmacy or a clinic or a hospital, and they don't have the people to do
Hmm.
this. They don't have the people with the right kind of training that your neighborhood chain pharmacy may have. Then instead of trying to use AI in your neighborhood chain pharmacy, which is for most practical purposes working okay, try visiting as many of the pharmacies in the Berkeley area. And most of them are working fine. They have most of the medicines you need in stock. If they don't, they'll tell you come back in a few hours, we'll have it delivered. In many cases, they will even home deliver to you, and so on. Right?
Hmm.
So, what are we going to achieve with AI in such a pharmacy? Well, maybe it will make it a little bit more productive. And more likely than not, we are going to essentially substitute some human effort with technology effort, which means we will need less pharmacy technicians, we will need less pharmacists per prescribing, per patient, and so on. So it's largely a productivity enhancing game. Now let's go to a pharmacy in a rural clinic in some rural part of India or some rural part of Africa or Central Asia, and then ask the question, what can technology such as AI do there? There isn't a pharmacist in many cases. There's no one who can do the ordering right. Um, in many cases, there's no trained physician or not even a nurse. So that's where the real potential of AI in healthcare sits. And this is important because in the trajectory of how we will use a technology as powerful for achieving impact in healthcare, in that trajectory, if we go back to the idea that we will use it largely to improve the productivity of a very well functioning pharmacy or a reasonably well functioning health system, and then call it quits, that is a failure of imagination of how technology impacts lives. Right? We've got to ask the question, can this substitute not just for productivity or for people who already are doing a task reasonably well, but can it fill a true white space? And that white space is large sections and swaths of population who have no doctor nearby, who have no pharmacist nearby, who have no nurse practitioner nearby, and technology can truly solve healthcare problems for them. And that is starting to happen in small pockets. That's what excites me the most. A pharmacy chain in Africa uses AI to make sure that the first interaction that a patient or a child's mother, in most cases it is the mom, who is interacting with an AI to figure out by answering a set of simple questions verbally through a chatbot or through some other communication channel, and then determining what's the next course of action for the child. Should they give her a medicine? Should they take the child to a hospital right away? Should they wait? Those are simple things that AI can solve. Similarly, diagnosis. There are lots of people in the world who do not have access to the kind of diagnostic infrastructure that you and I have access to, right? Leave aside MRI machines or CT scan machines. Most people in the world don't have access to anywhere being close to an X-ray machine that is working and there is somebody to interpret the results.
Yeah.
So why can't we use AI to solve those problems? And they are being solved, right? I mean, in particular for chest X-rays, we have seen the use of companies that have first started in solving this problem in rural India or in rural Africa by saying there is no radiologist who can look at the, even if you make the X-ray machine work, there's no radiologist who can read the radiogram. So
Yeah.
can we then use AI there, right? Those are places which get me a lot more excited than some of the applications I see for improving productivity, with one or two caveats, which is, faster development timelines for drugs help everywhere, everyone in the world. It'll help the patient in rural India at some point, maybe after a delay, a patient in Africa. Everyone will benefit when drug development becomes faster and speedier. So AI uses which are making drug development timelines compress are exciting opportunity. And I believe that that is an area where the impact will become much more visible. If it hasn't, it will become much more visible in the next few years to come, because the reality is that our ability to discover, develop, and launch new health products, medicines in particular, but other health products, the constraint there is the number of bright scientists we can put on solving that.
Yeah.
So if you have more scientists, you will get more drugs coming out. But if you have fewer scientists who are then helped by AI models to do their tasks faster, better, more efficient, and effectively, then yes, AI will create more drugs. Creating more safe and efficacious drugs will benefit everybody in the world. That's one part about AI that I get excited about. A last thing is, I hear from all colleagues who work at the front lines of healthcare, whether it's in the US, in Europe, in India, in Africa, they don't want to spend their time entering information into a electronic medical record system or some other kind of patient note transcribing thing, etc. They all think that's a very unproductive use of their time, which is true, right? They are the scarcest asset in the health system in many ways. Technology and AI, which is allowing that to change, whether it is through voice or other methods, so that very quickly whatever a physician has to do can be done instantaneously. That is another use which will help not just people in developed high-income health systems, but will equally impact healthcare providers who are in India, Africa, other parts of the world.
Yeah, and yeah, thank you for bringing up that point. I think also how you brought up like how AI could like lead to the development of more vaccines and drugs. Um so as you mentioned before with political environments, how would you suggest with rural areas, as you mentioned in India and Africa, like some people may be very conservative and they may not be open to like taking health advice or, maybe very kind of like focused on like just being against, having public health accessibility. So how would you give regards to that and scale the project for for global public health larger?
Yeah, so people have a lesser trust in information that comes from sources to which they do not have good social linkages, right? Again, I'm not saying this is well established in the literature on information sources and social linkages.
Mhm.
So whether it is the political environment, but I think irrespective of political environment, we ought to be asking the question that people trust information sources that have a strong social linkage with them when it comes to healthcare.
Mhm.
So if somebody creates an information channel which is, you know, information that is largely broadcast, and broadcast doesn't necessarily mean through a TV or a radio channel, it could be a website or whatever are the sort of, broadcasting methods, not non-targeted, not going through somebody people directly know, but just going untargeted. Broadcast channels of health information will always have had and will continue to have trust issues. We've got to establish ways of communicating about healthcare through social networks. And there are numerous examples of this. Even in my work, we look not so much on the demand side, but on the supply side, we are trying to understand social networks. Which pharmacist goes to which other pharmacist to figure out what are they giving when they see a patient with this kind of a condition. And that information flows amongst the pharmacists because they have a social network. In the social network, somebody has high cloud score,
Mhm.
implying somebody's influence is more than others. They are more connected to everybody else in the network. Right? So
Yeah.
the techniques of social network analyses are an extremely important and useful tool for how health information diffuses and how
Mhm.
health information should diffuse for it to be truly adopted.
Mhm.
Broadcasting health information doesn't get there. The second is direct versus indirect communication of health information, right? So oftentimes health information is tried to be communicated in a much more direct manner, which has benefits and is useful. But sometimes indirect methods also help, such as, changing social and cultural norms about healthcare seeking behavior only happens when TV, music, movies start embedding messages in a subtle manner. And that changes social and cultural norms and how people think about a particular health product, a health technology, or where to go to seek healthcare. Right? And
Mhm.
again, we've got to give those channels equal importance versus here is a PSA, like a public service announcement message of healthcare, and everybody listen to it and start adopting it. That doesn't work.
Mhm.
Also, we've seen, within like intra-family mapping of how healthcare information flows, right? So there have been multiple studies which have shown that, in particular, when it comes to obstetric and gynecological treatments and care, it is largely what we call as women's self-help groups, like women interacting with each other, where the best sources of diffusing such health information are. Similarly, when it's about nutritional patterns for pregnant women,
Mhm.
it is largely what people call as the grandmother effect, right? So the grandmother is the one who essentially is the biggest influencer, and not just of the pregnant woman, but also of the child in the first 100 days or the first 1,000 days of the
Mhm.
child's life. So again, knowing those points and creating targeted ways of getting information across to those points, we've come very, very far in advertising industry in targeting because we have data. The kinds of ads and the kind of yeah, sometimes it goes faulty, and I get all kinds of ads where I think, well, why are they sending me this? This just seems to have missed the point. But for the most part, ad targeting has used data science at its true level of advancement. We have not started using data science and ad targeting or message targeting as effectively for global public health yet. There are some
Mm.
efforts underway. So that's where I think the real people in the advertising targeting industry, I'm not talking about the creative advertising people who are important as well, but I'm talking about those who focus on data models for very, very precise targeted messaging. Can we
Mhm.
start involving them more in global public health? Where will we get, how will we then know how to reach the grandmother through the best channel possible, right? So those are things which are, again, these are in the works. Some people are trying it, but they're not mainstream yet.
Yeah, definitely. I think it's really about like what message you put out there and how people could perceive it. So, yeah, drawing from your own journey, what invaluable insights or pearls of wisdom would you impart to individuals embarking on similar paths?
Yeah, thank you for asking, Vaishali. I don't know if I can call them pearls of wisdom or wisdom of any form, but these are beliefs that I have had, which I think have helped me. One of them is in this concept of what I call as T-shaped knowledge, right? So get very deep in one area, but at the same time, keep your knowledge about areas connected to it or adjacent to it as rich as possible. And what that does is we know that innovation and the most impactful ideas are at the cusp of different disciplines. They rarely come from the same discipline. They come at the cusp of one discipline and the other. So physics and chemistry, physics and medicine, medicine and chemistry, right? That's where we've seen the biggest innovations come from. So same thing in global public health, right? I mean, I work on healthcare supply chain, so that's the deep line in my tea.
Hmm.
I have many colleagues who work on healthcare supply chains or in supply chains, but where I work differently from them is that the amount of time and effort I spend in expanding the top part of my tea, which is adjacent fields, whether it is epidemiology, political economy of health, healthcare provision, and economics, or healthcare and finance. Those are the aspects that allow you to become much better in the field in which you have depth. Right? So the depth of the T is directly proportional to how much you spent on the width of the top part of the T. Right?
Hmm.
So my advice to people is be very deep in one field. What you choose is up to you, where your interest, where your inclination, your affinity take you to. But when you go deep, make sure that you make it T-shaped and work on things that are adjacent to it. That's one personal belief that has helped me. The second is you learn from people's experiences by showing empathy to them. If I was to go and ask somebody, I'm a researcher or I'm a practicing consultant or I'm working on policy design, can you share some insights with me or can you help answer my questions? Yes, people will do it to some degree, maybe once. But when you show empathy, and when I say empathy means you try to become as embedded in their work and lives as you can,
Yeah.
right? That's when they feel you're not just a passive research types who's coming in and asking a few questions and will go on and write their research paper and then off. But you
Yeah.
are truly interested in what happens to their career. You are interested in the things that they struggle with every day in their lives, and maybe you'll try to bring some solutions, maybe not, right? It's not even that important to say I will solve your problem. You try to. What is
Yeah.
more important is I will do my best to understand your problem from your vantage point, from where you sit and stand,
Hmm.
not from my perch. And that is easier said than done, because it's not about making a field visit and going and hanging out with the people for a day or a few days. When you show empathy, then it is about I will put myself to your, or I will make myself available to whatever needs arise for you to fulfill what you're trying to accomplish,
Hmm.
and not tell you that this is outside the boundary of what I do in my work. So some may say, "Oh, I'm a researcher. Why would I get interested in solving somebody's promotion problem?"
Yeah.
I get deeply involved in solving people's promotion problem because I know that a core part of what I do depends on making sure that people who are contributing to advancing knowledge or are the ones who are taking good practices and implementing them,
Mm-hmm.
them advancing in their career is extremely important for me. In fact, sometimes it is more important for me than writing a research paper about the knowledge I acquired through the knowledge generation process, right? So
Yeah.
that's another sort of advice I have for people. Show empathy, and showing true empathy to people who you're working with is not as simple and straightforward. Sometimes it'll become taxing, it'll take times out of your days and evenings and weekends, but that's what it takes.
Yeah, definitely. And I think, as you mentioned, like being empathetic, and also like I think as you mentioned through like the user interview process, like, it's like I think it's really efficient if one can actually find a large scalable population, because I know some people tend to have maybe like 10 to 20 individuals, and you won't get, even if you do become really close to them, you need to see the larger impact as well. So, yeah, I think it's great advice. So yeah, thank you so much for being here today, and I hope to stay in touch.
Thank you for hosting me, Vaishali. This was great. Thank you again.
Yeah, thank you. Um, yeah, awesome.